Part 2 of respiratory failure is focused on assessing respiratory failure. You know your tools now, so we focus on working up the cause of respiratory failure and offer some different interventions and small treatments you can do while you're getting your team involved and while you're trying to, at bedside, figure out what you can do to make this patient more comfortable. And then lastly, we'll talk about different illness scripts that suggest the underlying cause of hypoxia or shortness of breath and things like that. So for new onset respiratory failure, I always kind of get back to your ABCs here, right? And in that sense, what's most important in respiratory failure is identifying things that are not going to let the patient, code or get much more sick or lose consciousness. So the key first thing is when you walk in the room, is their O2 sat over 90%? If that's happening, you're off to a good start. You want to look at how much oxygen they're on and be aware of that. And then now you're going to look at the patient as a whole, and some key points here is that person in respiratory distress, using accessory muscles. That would be a sign of instability. Look at the respiratory rate, and if it's crazy high, greater than 35, for example, that would be a sign of developing instability. And talk to the patient. If someone is so out of breath on the amount of oxygen that they're on that they can't speak to you or they can't get words out, that would be a big red flag. General workup to start would be just, get a VBG, especially if you're first one in the room. Go ahead and say, let's get a VBG, and repeat a one-view chest x-ray unless you had one done an hour ago. But if you did have an x-ray done in the last 2 or 3 hours and you had maybe not a lot of information based on that, talk to the senior, the team, or even yourself. Choose to do a CT. If you're just looking for pneumonia or something in the parenchyma, you really only need a non-contrast CT. There's pretty little risk in doing that. If you are concerned about pulmonary embolism, then you could do a CTA PE protocol. I would think hard before you do this on an inpatient. This is often done by the ER. We'll talk more about that later, but there's not too many circumstances where you'll be the one to diagnose a PE in the hospital, because I would say the sensitivity of the ER to identify that is quite high because they order that test a lot. We'll do a scenario here. You got somebody who's increasingly out of breath, O2 sats are dropping, and it's a 75-year-old who was on the floor, which is why you were called. You know that they were thought to have sepsis from the note from earlier in the day, and they have an acute kidney injury. Once you get there, the nurses have titrated the nasal cannula to 4 liters. O2 sats are over 90%. Feel good about that. However, you look at the patient, the respiratory rate is 38. Patient looks quite out of breath, breathing pretty heavily. That's not optimal. You get a blood gas, though, and the pH is 7.4. That's awesome. So what are we looking at here? I got somebody who's tachypnic, who feels out of breath, who's on oxygen, but is not on that much oxygen. It's a good sign as well. This patient could report to me or talk to me and tell me that they're out of breath. That's better than someone who can't do that, right? I got this x-ray here, and this x-ray is meant to demonstrate to you what somebody with developing pulmonary edema looks like. So let's say this patient got 4 liters of fluid today, and now they've got some effusions developing over here. You can see that the central spaces on the x-ray are pretty thick, plump, and enlarged, and the whole x-ray itself is starting to look, quote, whited out. And so this is somebody who, in this scenario, I'm going to look at and think, okay, I know that they have sepsis and they got a bunch of fluids today. Maybe they had CKD and now they have an AKI. Could a little bit of excess fluid or pulmonary edema be the cause of them feeling worse right now? The patient is not in distress, although I don't like the respiratory rate, and the patient's oxygen requirement is not that high. So what could we do here? My intervention here would be targeting pulmonary edema, most likely. At the same time, I would consider other things like pneumonia, but I would say if you could target pulmonary edema, make it better, and make them feel better in a short period of time, that's a good idea. So this patient, if their mental status is appropriate, I might offer CPAP to if they're uncomfortable on the 4 liters of oxygen, which he appears to be. But the CPAP really here is just to try and push air in, open up those alveoli, help them exchange air better despite all that water sitting in them. But that's going to hopefully immediately help this patient feel better. A more lasting approach to make them feel better, even if they have an AKI, is to see if you can make them pee some of that off. give them a dose of Lasix or a dose of Bumex intravenously. And I would just do a one-time dose. I might do 40 milligrams of Lasix. I might do Bumex, 1 milligram here. And I would try that and see if that helps them pee, put out some urine, and if their CPAP is making them feel better right now, I can come back in an hour and make sure that they still feel comfortable, and then see if they maybe just have pulmonary edema. And if that's the case, they should feel better pretty quickly with this treatment plan here. So let's try another scenario then. So I'll give you the exact same patient, exact same age, and the exact same chest x-ray. And let's say in this case, the patient does not become hypoxic. The patient has an O2 sat of 95% on room air, but the respiratory rate's still 35, and he still says he's short of breath. And we have his chest x-ray from the last slide showing he has pulmonary edema, okay? How would I handle this scenario differently than before? The answer to that is I wouldn't. I would still offer CPAP, and I would still try a dose of a diuretic. And I imagine that hopefully will help them feel better quickly. If that's not helping, or if the x-ray weren't looking like pulmonary edema, you would need to go back to the drawing board, ask yourself if this patient needs better imaging to identify a pneumonia that we haven't found yet, or you would have to look back and see if PE was considered at the time of admission, and if this patient has been getting DVT prophylaxis in the hospital, if they've been there for more than a day. But in this scenario, my point would be that the oxygen requirement is not what's driving me to consider my treatment plan. It's the comfort and the symptoms of the patient. So, and this is more just talking about someone who feels short of breath while they're resting and talking to you, or somebody whose respiratory rate is greater than 30. This should always concern you. You shouldn't be walking away or blowing off people who don't feel good. So if your tummy hurts and there's not really much going on, I don't know, that's something you can blow off every once in a while, give them some Tums. But, in this scenario, I just really want to point out that when you're talking to patients, if they're short of breath, especially short of breath at rest, as opposed to being short of breath only with exertion, that's an acute medical problem, and you should never disregard it. And again, I want to keep pointing out that I really just don't like to see people that are breathing greater than 30 times a minute. That should make you feel a little bit nervous. That should have your sphincter tightening up if you see somebody breathing up and up closer to 40 times a minute. But again, looking at many conditions that can make you feel short of breath, feel out of breath, but not have a drop on your O2 sats. Most people that I've admitted with pulmonary embolism have not necessarily been hypoxic. They may get hypotensive before they get hypoxic. It's very common. Med students or interns will tell me, well, this can't be a PE. This patient's not hypoxic. And that is a roundly inaccurate comment to make about qualifying who might have a PE or not. In general, somebody who has risk factors for PE, surgery, immobility, all the things that you all know from the Wells score, that's going to make me wonder about PE, in addition to somebody having shortness of breath, the symptom, and tachycardia. Those are the two things that get me going and excited to look for a PE. You could certainly not be tachycardic as well, but the severity of the PE is probably going to be identified in the hospital more so because they became tachycardic in the context of shortness of breath. So pulmonary edema, like we just talked about, can definitely be a lot more symptomatic as opposed to how much oxygen they require to point you in that direction. And then pneumonia is a mixed bag. I've seen people with consolidated lobes who barely need any oxygen. I've seen people that have a lot of consolidated or very minimal infiltrates on a CT or an X-ray, and they need quite a bit of oxygen. So determining, I certainly don't think it's the scope of our conversation here to be fixated on why people require oxygen and how much oxygen they require and making sense of it. Just be aware that you can't triage what's most likely happening based on who's on oxygen and who's not. You need to get symptoms and talk to the patient and get a history to get a better idea what the underlying driver is of symptoms and hypoxia when they're present. Last word here, past 20 seconds from now, if you are tired of me talking about benzos, but again, what happens when somebody feels out of breath and they feel breathless? They're going to tell the nurse they feel anxious, because they do. They feel anxious because they feel like they can't breathe. And okay, if it's a 30-year-old or a 20-year-old who's quite healthy, who was just told that they lost someone they love, or who told they had a bad medical diagnosis, sure, benzo away. It's anxiety. Anxiety in this context should not be treated as a symptom, just like you should not treat sinus tachycardia in somebody with sepsis. These are key pearls to prevent you from hurting patients. So anybody who's feeling out of breath and anxious, they're going to call you for anxiolytics. You're going to say, no, but let me come to bedside. Let me come work with you, offer breathing treatments. Let me come strategize with you in the RT to find some way to make this person feel better. That's how I handle anxiety in the context of breathlessness. It's an acute problem. It's not a symptom that I throw a sedative at. Let's do another scenario here with worsening hypoxia. You've got a 70-year-old person with pneumonia based on imaging from their admission, and you know they have a background of COPD, and now they've been on 2 liters of O2 all day, which is barely anything, and now overnight you're called because they're feeling more out of breath and their O2 sats are dropping. So you get in there, the nurse has already put this patient on the face mask called a non-rebreather, and it's attached to the oxygen behind the wall, and it's giving 100% oxygen. That's pretty much all they can do with a non-rebreather. They have to crank it up all the way to the top, and it gives 100% O2. It really can't be titrated. And you look at the patient, he's breathing in the 20s for the respiratory rate, not demonstrating any signs of distress. And you're talking to him, and he says, you know, I feel better with this on. I was feeling short of breath, but you know, when they put this mask on, I felt better. So his symptoms resolved when his O2 saturations were normalized, all right? And his VBG shows 7.32, which converted to, or you know, what an ABG would be, 7.35 or so. That's normal. I love that. And a CO2 of 54. He's ever so slightly retaining CO2. But what you know here is that this patient is having worsening hypoxic respiratory failure, and they have mild CO2 retention, but that's less so the acute part of what's going on here. And we know this patient has pneumonia, and you know, this is somebody who, you know, how long have they been in the hospital? What antibiotics are they on? So in this situation, what I'm going to be thinking about is, should I repeat an x-ray or other imaging? Okay, I want to give some breathing treatments to see if I can help them open the airways. I may even offer some breathing treatments focused on removing mucus if it seems like they have a purulent pneumonia. We'll get more to that later. And I don't know that yet. Well, actually, if they're going to require this much oxygen, you'd have to transfer them to the step-down unit, because that's too much oxygen to be on the floor. But the next thing I would look at is what antibiotics are they on. If they're on ceftriaxone, azithromycin, you know, and they're getting worse like this in the hospital, you might consider broadening out their coverage. Again, just like with the old case we did before, if you've got an x-ray and they look like they're developing pulmonary edema, you know, in the worst scenario, that could be ARDS developing, but in someone who otherwise looks pretty good, it could certainly just be some superimposed pulmonary edema. You're definitely allowed to have multiple things going on, right? You could have pneumonia, and you could develop wheezing in the context of having known COPD, and in that scenario, you might try some steroids, okay, if they're wheezing. But additionally, if they have a background of heart failure or diastolic dysfunction, and they feel more short of breath because they've been in the hospital for 12 hours and they got 3 liters of fluid earlier, their pneumonia might be being treated appropriately, and they might just be developing superimposed edema, which just needs a diuretic dose. You're probably not going to fail anyone's kidneys, or I'm at least not aware of anyone's kidneys failing from getting a single dose of a diuretic at night or during the day. So it's certainly not a bad idea if you have a hunch that there's a component of edema. But in general, just be aware that multiple things can be going on. Let's do another scenario here. Somebody whose oxygen seems okay. You got a 70-year-old who has COPD. He's admitted here with pneumonia. Sounds familiar. And you're called because now he's got worsening shortness of breath. You go to the bedside and he is sitting up, leaning forward, and he's just telling you, I can't move air, doc, and he's having trouble even getting words out to you because he's so breathless. And you look at him and his neck muscles are moving abnormally, His chest wall is barely moving despite him breathing 39 times a minute. And again, we've got this severe tachypnea on here again. But, oh, well, he's on 2 liters of oxygen and his O2 sat is 96%. So, well, he can't be that sick, right? Wrong. He could be profoundly sick. In fact, he's, about to pass out and be unresponsive if we don't do something right now. So that pH, 7.18, is a huge problem. PCO274, respiratory acidosis. Breathing 40 times a minute. He's air trapping. He's not blowing off CO2 effectively. Has a background of COPD. His pneumonia is not helping either. But this is a person whose hypoxia is way less of a problem than his hypercarbia. At any rate, what are we going to do now? This person is probably going to need to go to the ICU, so you're going to want to make that phone call while you are at bedside trying to figure out what else you can do to keep this patient from losing their airway or losing their consciousness. So if the patient's awake and follows commands, this is a time to try BiPAP. This is what BiPAP was invented for. So you try the BiPAP here and see if you can help to resolve their respiratory distress. With the BiPAP, you're going to try duonebs. I would give 3 duonebs back to back to back here. And, I'm not going to leave bedside. This is a severe acute emergency. This person needs to be fixed right now. But as I'm doing these things, this person has already earned an ICU consult. If the ICU comes and the BiPAP and your duonebs have actually helped and the patient looks better and they feel like he doesn't need to come to the ICU, then great. Then you still did the right thing by calling the appropriate level of support at that moment. And if someone got better, then everyone feels better about it. You also certainly want to tell your team, tell your attending, anytime someone's O2 is going up in the morning, more than, if someone's on more than 2 liters of oxygen and that number's gone up from the day prior, I would be telling my senior and I'd be communicating that to my team on rounds. That's just information that really highlights that you understand that someone's getting sicker. Airway rattling, okay? My favorite thing is when I go into a room and somebody's doing that airway rattling thing in the context of hypoxia, and somebody tells me that that's pulmonary edema. You don't hear pulmonary edema from across the room. You hear secretions. You hear active aspiration of secretions from poor mental status and inability to clear mucus. So that's what you're hearing, is someone who's actively aspirating or actively aspirating their own secretions, okay? So that's what I'm picturing for you here. Somebody whose respiratory rate is in the 30s, he's now on a non-rebreather and was not on oxygen earlier in the day. The classic sign that somebody had a frank aspiration event, and this has happened at least 6 times in my training, I go to bedside in this context, there's a dinner tray within 3 feet of the patient with some half-eaten graham crackers and pudding, and I think that is fairly indicative of what likely happened in the seconds leading up to this patient developing respiratory distress. So get an x-ray, and the x-ray just, here's the right lung and here's where the infiltrate is. So whatever that patient was eating for dinner is now in the right lower lobe. So how you handle this really depends on how profound the respiratory distress is. If it's severe respiratory distress and they're severely hypoxic and it's not stabilizing on the face mask or whatever form of oxygen that they have on, then you probably have to call ICU and they may need to be intubated. However, sometimes I'll try some suctioning with the RT, see if they can suck out some goobers, clear the airway out, do some chest physiotherapy acutely to see if they can help to shake out some goobers. Make the patient NPO at that point in time so that they can't make the problem any worse. No food, no water, and a speech-language pathology consult the next day most likely. And usually antibiotics are not necessary in this context. The problem is these people can get aspiration pneumonitis. They can get extremely unstable very quickly, and they can rage and cage with high vital signs and fevers for 12 to 18 hours or up to a day. And later on, they can develop into a true bacterial pneumonia because they certainly aspirated down contents that weren't sterile. So this is a nidus to develop an infection with time, in my opinion and experience. But in general, your key intervention here is support. You're going to try and support their breathing with oxygen. You cannot do BiPAP here. BiPAP's a no-go. CPAP's a no-go, even if you think it might help. You just don't want to do that here. If the oxygen you're giving isn't enough, you got to call for extra help. But, you know, if you get to the bedside and they're still awake and their O2 sats are okay, you can often tool around with supportive care and find a way to help these people get through what's going on. But just another word on aspiration is that whether it's a big aspiration event like that from dinner, or it's a smaller micro aspiration or a subtle aspiration event just on water or on their own secretions, you know, this happens all the time. Incredibly common in elderly people, people with a history of strokes. If your patients have altered mental status, hypoactive delirium, and their level of arousability is poor, then they're going to be at risk for, you know, sucking down their own secretions and aspirating if they're given a diet. And I think it's key as the intern to be aware that, you know, whatever you choose as the dietary option for your patient matters. If somebody is frankly altered, let's say someone's post-ictal and they're barely able to wake up and talk to you, you definitely don't want to give that patient a regular diet until they've woken up and demonstrated that they can do a competent bedside swallow. If you're at the step-down unit or the ICU, some of the nurses will ask you if they can try a bedside swallow. They feel confident, or the patient's demonstrating signs that they're going to do well. They're awake and following commands very well. You know, in those circumstances, I work with the nurse, and if they feel like it went well, we can try something like a thick liquid diet or a dysphagia diet temporarily while waiting for an SLP consult. But I just feel like this is under-recognized, and a lot of people who are getting worse in the hospital, you'll see people reaching for antifungal antibiotics and reaching for more broad bacterial antibiotics. And if you just look at the clinical picture, if you're at bedside looking at the patient and looking at what's happening, you know, oftentimes there's a lot of people who have non-resolving oxygen requirements or who wax and wane in how sick they are because they're actively aspirating. Use the speech-language pathology consult service. They're your friend. They're very good, and they help you identify these micro aspirations and frank aspirations, and they're critical in helping to advance the diet once you know somebody is aspirating. So they're great utility, and I use them a lot in my training here. Mucus plugging is very similar to the concept of someone who's aspirating, but it's different in some sense. So there are people who are just mucus formers. You know, you've got your classic CF patients, but in the hospital, you've got people who have a propensity to plug their airways. And there may be people who are in the ICU who got extubated, people who had pneumonia and have thick secretions. When those thick secretions block up big airways, they can drop an entire lung, as I pictured here for you. That would be classic for somebody who just plugged a major airway with mucus. And be aware that that can be a cause of cardiac arrest. That can make people profoundly unstable for even just a few minutes, but it's a big deal. And people, you know, this happens all the time, but small airway plugging and just thick secretions that are clogging up the airways are a problem in a much less severe context all the time. And just like in the last slide, I talked about people that wax and wane, who have a non-resolving oxygen requirement, especially people who had pneumonia. These people may just have issues of mucus clearance, and I often start a treatment plan for these people that I learned in the ICU called Airway clearance. We'll get more to that in a minute. So you're treating the pneumonia, they still got all this mucus and they're still requiring oxygen. You need to help them get mucus up and out. And for somebody who dropped their lung like this, some breathing treatments probably aren't going to be enough. You're probably going to have to call pulmonary, do a bronchoscopy. Oftentimes this is going to have to happen in the ICU for someone who's dropped their lung like that. Managing secretions and mucus, just like in the last slide, what I do is I work with RT, and I like this treatment called inhaled pulmonary, I think it's ventilated, IPV is what it's called. But in general, we use it in the medical ICU, and it blows air in like with some pressure, and it involves the patient taking a breath while it's doing this, and it's blowing in first albuterol, and then you follow that with 3% saline, and the albuterol dilates the airway. The 3% saline is going to help to thin out and loosen secretions and mucus. And the air movement with the IPV helps to sort of get the mucus loose, and once that's happening, often the patients feel a desire to cough and start coughing it up. So this is a way to clear out mucus, and it's my preferred go-to, and most of us prefer to do this if the patient can do it. So someone who's able to follow commands, work with the RT, IPV is a good option. For someone who's maybe a little bit more not really able to follow commands, someone who's advanced dementia, for example, then you might need to do manual chest PT. The RT will come and chisel on their back and kind of beat on them and try to loosen up the secretions. They may also try deep suctioning through the nose to try and get down into the trachea and get out mucus. But I still use the same treatments in this population, but the IPV, that mode of delivering the treatments, is only if you can follow commands. So these people would need nebulized albuterol and 3% saline. A key point, or at least a key, sort of myth, witchcraft, or maybe, legit data to support it, but I would say in my training, we always talked about avoiding ipratropium and other anticholinergics because they could thicken and dry out secretions, and that's something you don't want to do because you want to get them up and out. So I typically give albuterol without ipratropium, followed by the 3% saline, because I think it's the cleanest way to help get the secretions up and out of there. But work with your RT to just try to find a solution to meet the goals of everybody, which is to help these patients wean off oxygen and feel better. Another note, anybody who's asking you to give somebody scopolamine for somebody who needs oxygen or somebody who's got secretions, please say no. That's just a terrible idea unless this is an end-of-life situation. Scopolamine patches are profoundly anticholinergic. They can cause delirium, urinary retention, all the things that are bad, in addition to drying secretions and preventing you from doing what you need to do with those secretions, which is getting them up and out. And the other thing here is that if the heart rate is greater than 100, it's common for nurses and RTs to tell you that you can't use albuterol. I disagree with that. I've never been in a situation where I couldn't use albuterol. If somebody's heart rate is 120 for 2 minutes and then goes back down to 105, I don't think that's significant. So I use albuterol even if the patient is slightly tachycardic. Sure, if somebody's in SVT, heart rate greater than 140, I will not use albuterol because it has a slight increase in the heart rate. But I do not switch patients to ipratropium who have pneumonia or mucus issues just because they have a little bit of tachycardia. Their tachycardia is often driven by being septic or having a pneumonia or being agitated or in the hospital. So, not using albuterol is not going to really improve the tachycardia, and the albuterol is often not going to make it much worse either. Let's talk about some different diagnoses. Pulmonary embolism, we hit on a little bit earlier, but I think it's just people love to think about PE and they love to test for PE, but if you do your pre-test probability and think through that and think who really needs to go down for a CT scan to look for a PE, you should be able to talk yourself out of it unless you have a good reason to do it. So if somebody has been in the hospital for a couple of days, they've been getting Lovenox or heparin and or subcutaneous devices to squeeze their legs, I don't usually think that's somebody who's about to have a PE. There's probably data to show that these people are pretty low risk for developing PE unless they're highly thrombophilic. And again, the ER has a very high sensitivity of detecting PEs of all sizes, ranging from life-threatening to minuscule, and PEs that are so small that they probably don't warrant treatment. So the ER performs CTAs on such a high fraction of people that it's not common for us to have somebody who was admitted that we're thinking, man, should we rule out PE? Because it's often been ruled out. And once it's ruled out, if it's just a day or two later, I really wouldn't be thinking about ruling it out again. But let's say that they didn't rule it out, and let's say that this patient has some risk factors, whether it's a recent surgery, immobility, or maybe somebody held their heparin because they forgot to order it, or maybe they just felt like the patient's platelet count was below 50 and they were too worried, so they didn't order DVT prophylaxis. So some signs that when I would be considering PE, I've got a chest x-ray, and that chest x-ray doesn't show why the patient is short of breath. Okay, that's when I would start to smell the PE a little bit more, and I would also be suspicious if they have tachycardia. And shortness of breath plus tachycardia with a normal chest x-ray, to me, is an illness script that would start to support PE. And if you ever encounter somebody who you already know has a PE and has been in the hospital for a day or two with PE, who's getting sicker, hypotensive, hypoxic, whatever, that is an ICU consult immediately. That's somebody who's in a very, very dire situation. So for pulmonary edema, we've actually talked about this quite a bit, but we talked about how the chest x-ray would show the central fluffiness, the central congestion of the vessels, and we'll show just white, fluffy appearance bilaterally. And again, I want to highlight to you that pulmonary edema will often be symptomatic to a greater extent than the patient will necessarily be hypoxic. So always think about pulmonary edema if the patient's net fluid positive by a lot, and if they're older, especially if they already have known CHF or if you know their EF is low. Somebody who has ESRD or advanced CKD, obviously start thinking about this a lot sooner if they're feeling short of breath. Getting a unit of blood if you're an ESRD patient is enough to probably tip you over and make you develop some pulmonary edema. So just be aware of that and start thinking about calling nephrology to help with some dialysis if you're in that situation. And then you can develop acute pulmonary edema even if you don't have heart failure. If your blood pressure, is greater than 200 or 190 systolic, these people can develop what we call flash pulmonary edema and flood their lungs with fluid. That can happen so rapidly that these people can be chilling on room air and then hit that point where they develop flash pulmonary edema and they're in respiratory distress. They actually get intubated quite a bit in the ER because of the degree of distress they have. So flash pulmonary edema is not subtle. If somebody's got a little bit of shortness of breath and they're hypertensive, that's not flash pulmonary edema. Management of pulmonary edema, if your patient is not able to make urine, then you just need to get on the phone and call nephrology. And someone who's just so short of breath they're not comfortable, they can't sleep at night, or if I have them on a CPAP for pulmonary edema, that is an urgent/emergent indication to do dialysis, and they'll come and do that any time of day in the step-down unit. Somebody who makes urine, let's say your standard heart failure patient, I'm going to offer them some CPAP to help make them comfortable, and we're going to give them some Lasix or Bumex to help them pee it out. If they have a little bit of an AKI, I'm still going to do this, and you can be mad at me, but again, I've never seen a dose of Lasix fail someone's kidneys, and I like the kidneys a lot. I believe in good kidneys. See my lecture on acute kidney injury. And my threshold to make the decision to give a single dose of Lasix or Bumex is lower than it is to order other treatments, because if you know a little bit about patients with pneumonia and sepsis, and if you know a little bit about the literature of ARDS, you come to the simple phrase, dry lungs are happy lungs. And so if somebody's a little bit wet, they're often going to feel a little bit better, and potentially their lung function will be a little bit better if you dry them out a little bit. Same is true for COVID-19, right? Those patients you try to do less fluid with because their lungs don't like it when they get wet. So remember, dry lungs are happy lungs. Keep thinking of that. A dose of Lasix is usually okay to consider if you're already thinking about it. Usually just do it. COPD exacerbations, highly, highly common, especially if you're over at the VA. But these people may not require a whole lot of oxygen. They may only be on 1, 2, 3 liters. But I run to this diagnosis, especially if somebody is having a lot of wheezing. And generally speaking, if somebody's wheezing but they're comfortable and they're just on nasal cannula, they can be on the floor. The thing with COPD exacerbations is they can have such dynamic fluctuations. They can be looking so good you're thinking about sending them home, and then something flips them off. They turn over to pee, or something startles them, and then they start wheezing, and then they start air trapping, then they get anxious, and they get more tachypnic, and then they can go into respiratory distress very, very rapidly. Now, that's not very common, but just be aware it can happen. And standard management for these patients is going to be duo-nebs, Q4, and more frequently if they still need more to help open their airways and feel comfortable, prednisone and azithromycin for 5 days is pretty standard. I think it's always appropriate to get a first VBG if it wasn't done in the ER. Get a VBG just to make sure that they're not retaining CO2 and developing acidosis. And if they're not and they're comfortable, then you're looking good. And again, try to avoid titrating oxygen up to 100% because excess oxygen is not necessarily good. A word on pneumonia. We did a sepsis lecture. If you see that, there's some stuff about pneumonia in there. But if you're requiring oxygen and you're not someone who has chronic respiratory disease, pneumonia is a pretty common reason to be in that boat. And a chest x-ray with some opacity anywhere about is probably an infiltrate, and that's probably a reason I think they have pneumonia if they have cough plus fever or sepsis. But certainly there's lots of people with pneumonia who never have fever and who don't become systemically septic. But my favorite illness script for pneumonia is a productive cough and chills or fever. And that, when I get that together, I'm not searching for anything else. That's pneumonia. And just one word to point out here is that if you had somebody who tested positive for the flu or another virus, and that patient, a few days later is looking a little bit better, but then they get sick again and they're requiring new oxygen, that could be a post-viral pneumonia. That would be highly concerning for an MRSA infection. And remember that association. That's one of those associations that I remember getting tested on all the way back in step 1 that I think clinically is actually pretty accurate. That's happened several times in residency, so I would have an eye out for that clinical context. So people with pneumonia who are starting to get better or throughout their admission, but once their respiratory status is somewhat stable, your next goal is to try and wean their O2, right? And part of the way you're going to do that is by helping to open their airways and remove whatever mucus is left in the airway. So airway clearance, as talked about a few slides ago, is another key, in my opinion, to helping to get these patients up and out of the hospital. Again, just be aware that you can have multiple things. You can certainly have pneumonia and develop pulmonary edema, or start wheezing and develop what clinically looks like a COPD exacerbation. Steroids in the context of having a community-acquired pneumonia or just pneumonia in general, steroids are not harmful. In fact, there may be some benefit based on some limited evidence. So if somebody has COPD and they're wheezing, and they have pneumonia, then give them some steroids. And I would treat them as if they had a COPD exacerbation and just continue the antibiotics for the pneumonia. And that has worked well in the experience that I've had in that context. Lastly, again, too much oxygen is bad. Well, it's probably bad in COPD, probably bad in everything, but in COPD it can be meaningful. You titrate someone's oxygen up to 100% and they start retaining CO2, they could lose their airway, become unarousable, need to be intubated. So just be aware that if you can titrate a COPD patient's oxygen to 88 to 90%, that'd be great. That would be more optimal than 100%. The biggest reason that people retain CO2 if they have COPD, they retain CO2 if you titrate their oxygen too high, is because of VQ mismatch. You're throwing oxygen all throughout the lung in areas that aren't able to perfuse and blow off CO2, hence you're causing VQ mismatch. And for your patients that are just on this smidge of oxygen, 1 to 2 liters of nasal cannula, this is just the bane of my existence. I don't know. There's not many acute processes that just put you on 1 liter of oxygen. But when you're in the hospital, it is an epidemic that if someone's O2 sat drops once at night transiently and it's caught on a telemetry box, somebody goes in that room and puts the patient on nasal cannula. And the hallmark of that is you get there in the morning as the intern, you're running on the patient, they're on 2 liters of oxygen, and they weren't on oxygen yesterday when you admitted them. And it's probably somebody who has undiagnosed sleep apnea who had an asymptomatic desaturation at night. Had nothing been done, they would have still woken up in a second or two and been like, because that's what they do. I probably do that 8 times a night in my own sleep. So this is an epidemic. Happens all the time. Is it that harmful for staff to put a little bit of oxygen on people? Probably not super harmful, but it's unnecessary. It's not uncommon for interns to be shook up and, man, I can't discharge this patient. Now they have an oxygen requirement. And honestly, the first thing I do on rounds, if I think that someone doesn't really need oxygen in this context, I'll turn it off and we'll see how they do. And I often try to avoid even doing walking oxygen tests on these people to see if they need home oxygen. If it seems like it was just an overnight random asymptomatic event. So just really, if it doesn't make sense, remember this is something that can be going on to help clarify what's going on there. Okay, that's a fairly comprehensive overview. Some things we didn't cover here right now. We didn't cover pneumothorax. That's really something that you probably will be working with other people to solve if that happens. We didn't talk about ILD. There's not much as the intern you can do for ILD. There's not much you can do if you're higher level of training for ILD. ILD, if it's requiring more oxygen than you can give, needs to be in the ICU, and that would be the case often before that happens. So this is a hopefully helpful practical overview, but I'm interested to hear what you all think.